Hello, I'm Nicole Scappy, and I have a Willebrand disease, along with my 4 siblings and my mom. I wasn't diagnosed until I was 13. And the only reason I was diagnosed is that my mom's severe bleeding issues led her to a hematologist who pointed us to a hemophilia treatment center. I've experienced my own trials and tribulations that left me feeling hopeless and fearful of my future. However, I've had the pleasure of watching our VWD presence grow over the last 15 years or so. We have come so far in treatment advances, yet so many still struggle to receive a diagnosis or quality care. I was thrilled when I was asked to join my group, as I just finished serving as a panelist for the new VWD guidelines, which was over about 4 years of work. And my experience on the diagnostic panel helped me navigate through a high-level working group meetings, discussions, and so whenever I was asked to participate, I was 100% in and ready to go. And it's been amazing having so many different perspectives in our group. And Dr. Flood and Dr. Sidonio, I just want to give you a shout out. You have been the absolute best co-chairs, ensuring all voices are heard during our meetings. In addition, I'd like to give one more shout out to the folks behind the scenes that are making the State of the Science happen at NHF. So shout out to that entire team, the research team at NHF. And also through this experience, the guidelines, I've learned how vital every voice is. Sometimes I'd be quiet, but that doesn't help anyone. So I've learned to speak up when I disagree or have a thought that others may not have. Everyone should be excited that we are making a blueprint for future research. This is huge for the VWD community. I'm thankful to NHF and all those participating in the State of the Science for their commitment to making the world a better place for all those with bleeding disorders. Thank you.
Okay, good morning, everyone. First of all, I would like to thank the organizing committee for the invitation to give this presentation. I am going to talk about understanding phenotypic variability in von Willebrand disease and its implications for diagnosis and treatment. These are my conflict of interest disclosures. And this is an overview of my presentation. I'm going to begin with a brief introduction to von Willebrand disease. Then I'm going to discuss the state of the art regarding von Willebrand disease classification and guidelines. In the main body of the presentation, I'm going to consider key unanswered research questions regarding von Willebrand disease. And the final part of the presentation, I'm going to look towards the future. So by way of background, you'll all be aware that von Willebrand disease was first described by Eric von Willebrand back in 1926. He described the index case of a 13-year-old girl who developed fatal bleeding with her 4th period. This girl came from a family with significant bleeding from the Åland Islands off the coast of Finland and Sweden. This is the family tree of the original index case who's shown with the red arrow. As you can see, the striking difference here compared to hemophilia is that both males and females are affected, which led to its original title of hereditary pseudohemophilia. Since 1926, things have progressed significantly. We now know that von Willebrand disease is the commonest inherited human bleeding disorder, affecting something like 1 in 1,000 subjects. It is characterized by mucocutaneous bleeding, typically nosebleeds, gum bleeding, easy bruising, menorrhagia, and of course bleeding after trauma or surgeries. In rare patients with type 3 von Willebrand disease, we also see joint and muscle bleeds. We have gained significant insights into the pathogenesis of von Willebrand disease, and in particular recently into the pathogenesis underlying quantitative von Willebrand disease. This has come from a number of cohort studies, including the European Union MCMDM study, as well as studies from the UK HCDO, from Canada and from Italy. More recently, we have the US Zimmerman program, the WIN study in the Netherlands, and the Irish LOVIC study. All of this research into von Willebrand disease has led to an enormous number of publications. So a PubMed search performed in late July demonstrated that there were more than 25,000 papers on von Willebrand disease on PubMed. We have gained insights into von Willebrand factor biology. We know that VWF is synthesized within endothelial cells and megakaryocytes. It's initially synthesized as a long polypeptide, which consists of a 22 amino acid signal peptide, a 741 amino acid propeptide, and a 2050 amino acid VWF monomer. We know that functional properties of von Willebrand factor have been mapped to individual domains. For example, the main factor VIII binding site is located at the N-terminal end. The GP1B alpha binding site is located within the A1 domain. The principal collagen binding site is located in the A3 domain, and the ADAMTS13 cleavage site is located within A2. Prior to secretion from endothelial cells and from platelets, von Willebrand factor undergoes significant multimerization. This begins in the endoplasmic reticulum, where C-terminal disulfide bond formation links monomers into dimers. Subsequently, in the Golgi, the VWF dimers are assembled into long multimeric chains by another round of N-terminal disulfide bond formation. This VWF multimer distribution is important because it's a critical determinant of functional activity, so that the longer multimers are able to bind to collagen and to GP1B alpha with significantly increased affinity. In normal plasma, VWF multimer distribution is of course regulated by ADAMTS13. Multimeric VWF plays a key role in normal hemostasis. VWF is able to bind to exposed collagen at sites of vascular injury and becomes unwound by shear stress. The unwound VWF is then able to bind to platelet GP1B alpha, thereby tethering circulating platelets at sites of vascular injury. The VWF binding also triggers platelet activation, which leads to platelet aggregation and ultimately platelet plug formation. Besides these functions in primary hemostasis, VWF also serves as a carrier protein for procoagulant factor VIII. This VWF interaction is important because it stabilizes factor VIII and protects it against premature proteolysis and clearance, such that the half-life of VWF bound factor VIII is 12 hours, whereas the half-life of free factor VIII in plasma is only 2 hours. So let's consider the state of the art regarding von Willebrand disease classification and clinical guidelines. For many years, von Willebrand disease has been subclassified as either quantitative or qualitative. Quantitative von Willebrand disease accounts for approximately 75% of cases. Because it involves a quantitative deficiency, there is a proportionate reduction in von Willebrand factor antigen and von Willebrand factor functional activities, regardless of which functional assay we look at. In normal plasma, von Willebrand factor antigen levels are typically in the range between 50 and 150 international units per deciliter. There are two types of quantitative von Willebrand disease. In type 1 von Willebrand disease, there is a partial quantitative reduction in plasma VWF antigen levels less than 50 IU per deciliter. Whereas in type 3 von Willebrand disease, we see virtually complete deficiency of VWF with levels less than 3 IU per deciliter. Qualitative VWD accounts for approximately 25% of clinical cases. This is characterized by secretion of a dysfunctional VWF molecule. Consequently, there is a disproportionate reduction in some or all of the functional assays compared to the antigen levels. So the antigen levels may be normal or near normal, whereas one or more of the functional assays are markedly reduced, such that the hallmark of type 2 von Willebrand disease is that the function to antigen ratio is reduced to less than 0.7. Qualitative VWD is further subdivided on the basis of specific phenotypic characteristics. So type 2A von Willebrand disease involves qualitative variants that have reduced platelet adhesion and loss of high molecular multimers. Type 2M von Willebrand disease incorporates variants that have reduced platelet adhesion not caused by loss of high molecular multimers. Type 2B von Willebrand disease includes VWI variants that have increased affinity for platelet GP1B alpha. And finally, type 2N von Willebrand disease is characterized by VWI variants that have decreased affinity for factor VIII. Over the last decade or so, there have been a series of expert consensus guidelines published on von Willebrand disease, including guidelines from the NHLBI, the European Union, and the UK HCDO guidelines, most recently updated in 2014. Of course, all of you will know that there also has been a recent joint initiative to update the von Willebrand disease guidelines. This has come from the American Society of Hematology, the ISTH, the WFH, and the National Haemophilia Foundation, and has had strict methodology, which has been led by the University of Kansas. These new guidelines involve clinicians and scientists interested in von Willebrand disease who were assembled into two panels dealing with diagnosis and treatment respectively. Conflicts of interest were declared and assessed, and critically there was strong patient involvement into both of these panels. At the outset of the guideline development, there was an international survey to identify topics that were of highest priority to stakeholders in the field. This international survey gained 601 responses from right across the world, as you can see in the panel. Overall, the responses were split approximately 50-50 between patients and caregivers vis-a-vis healthcare providers. The highest priority topics that were identified from that survey included things relating to diagnostic criteria and classification, bleeding assessment tools, and treatment options for women and surgical patients. Based on the survey responses, a series of PICO questions were developed, and ultimately 10 questions were addressed by the diagnosis panel and 12 questions were addressed by the management panel. And for each of those questions, a systematic review of the evidence was performed in detail. Ultimately, all of this work led to the publication of the combined guidelines earlier this year in Blood Advances, a guideline on diagnosis followed by one on management. These guidelines are freely available on the internet, and I don't have time to go through all of the recommendations in detail, but the highlights are shown on this slide. As you can see, the panel guidelines were focused really on the questions that had been generated from the international survey. In the same issue of Blood Advances, there was also a guideline published on the management of von Willebrand disease. And again, a series of recommendations were made by the guidelines based on the questions that had been raised from the survey. So, what's the state of the art? Well, we have our newly minted consensus guidelines published earlier this year. These guidelines, in my opinion, provide an exemplar model of how guidelines should be produced. I think we need to acknowledge the fact that they have involved a massive amount of work, and in particular, incredible effort and dedication from the project leaders, Veronica Flood, Paula James, Nathan Connell, and all of the people from the University of Kansas who impacted this process. I think everyone who's working in the von Willebrand disease certainly owes a debt of thanks to these individuals for leading this process. So we have two newly minted guidelines that are based on 25,000 peer-reviewed publications. So happy days, we should be sorted, I guess, but perhaps we should give this some thought. Looking at the guideline recommendations that are present in the ASH, ISTH, NHF, WFH guidelines, the first thing that is striking is that almost all of the recommendations are suggestions rather than recommendations, which reflects the level of evidence that the guidelines are based upon. Similarly, for the management guidelines, again here, all of the recommendations are actually suggestions. So the guidelines include a recommendation on how this evidence should be interpreted. So if you look at the right of this table, you can see that where the guideline states the panels suggest, for the patients, that means that a majority of individuals would want the intervention, but many would not. For the clinician, where it says the panel suggests, that means that different choices will be appropriate for individual patients depending on their values and preferences, and that we need to have shared decision making. So this is not at all clear-cut. The guidelines also highlight the critical need that we have for further research in the von Willebrand disease field. So for researchers, the panel suggests means that the recommendation is likely to be strengthened by additional research and helps to identify possible research gaps. So what are those gaps, and what are the key unanswered research questions that we still have in the von Willebrand disease field? Well, the first research question that needs to be addressed is that we don't understand the relationship between reduced von Willebrand factor levels and bleeding risk. This question was highlighted by Evan Sadler in a series of seminal opinion pieces that he published almost 20 years ago. This is a figure from one of Evan's publications. As you can see in the orange line, as the von Willebrand factor levels decrease, then the risk of bleeding in the red line starts to increase. Of course, what we don't know is whether that increase in bleeding risk is really linear. In addition, we also suspect that there are going to be marked inter-individual variations in terms of how that bleeding risk correlates with von Willebrand factor levels. This question is perhaps best exemplified by patients who have mild to moderate reductions in plasma von Willebrand factor levels in the 30 to 50 IU per deciliter range. In previous guidelines, these patients were defined as being low von Willebrand factor. This is an important subgroup within quantitative von Willebrand disease. For example, low von Willebrand factor actually accounts for 60% of the total von Willebrand disease registry in Ireland. In addition, this diagnosis has been estimated to apply to perhaps more than 7.5 million people in the US alone. So for these patients with low VWF, we have a number of important questions. Do patients with low VWF actually have significant bleeding histories? If they do bleed, what type of bleeding do these patients experience? Is there a critical von Willebrand factor threshold level? And in particular, is there a difference in bleeding for patients who have levels between 30 and 40 IU per deciliter compared to those who have levels in the 40 to 50 range? In order to address those questions, a number of years ago, we set up the Low von Willebrand Factor Ireland cohort study, or LOVIC study. From our data, it was clear that some patients with low VWF do display very significant bleeding phenotypes. So as you can see here, using the ISTH BAT score on the left or the condensed MCM-DM bleeding score on the right, more than 70% of females in that study had abnormal BAT scores. And in fact, more than a third of them had ISTH BAT scores in excess of 10. So these data are clearly telling us that some people are experiencing bleeding that appears to be disproportionate compared to the modest reduction in their plasma von Willebrand factor levels. Interestingly, Veronica Flood and colleagues have observed very similar data regarding bleeding phenotype for the low VWF cohort that are enrolled within the Zimmerman program. So as you can see on the figure there, more than 60% of patients with low VWF had abnormal ISTH BAT scores in the Zimmerman program. Why are these patients with mild to moderate reductions in plasma VWF levels actually bleeding? Well, the first important thing to take home is that bleeding does not correlate with plasma von Willebrand factor levels in the 30 to 50 range, so that the ISTH BAT score and the condensed MCM-DM score are identical for patients who have levels in the 30 to 40 range, as opposed to those who have levels in the 40 to 50 range. Once again, there are similar data from the Zimmerman program. You can see here that the number of people with an abnormal bleeding score was similar for those between 30 and 39 compared to those in the 40 to 49 range. And in fact, overall, the bleeding scores were very similar for people who had von Willebrand factor levels, anything above 10 right up to 50. The bleeding that we are seeing in these patients with low VWF cannot be explained by abnormal multimers. These are data from the Lovick study, multimers that were done in Ulrich Buda's lab in Hamburg. And as you can see, we identified abnormal multimers in only 4 out of the 126 patients that we studied, and all of those 4 individuals had the same sequence variant. In addition, as part of the Lovick study, we did an extensive bleeding state workup in these patients, which included factor assays, platelet aggregation, factor 13 levels, platelet nucleotides, and PFA 100. Out of more than 100 individuals, only 10 subjects were identified who had evidence of other concomitant bleeding abnormalities. And importantly, the ISTH BAT scores were the same for low VWF people, regardless of whether or not they had a concomitant hemostatic defect. So the bleeding that we're seeing in these people cannot be explained by concomitant hemostatic abnormalities. Putting all of this together, it's clear that some people with low VWF have a bleeding phenotype that can be quite severe, but that we cannot explain. In that context, we clearly have a degree of overlap with patients who we register with having bleeding disorders of unknown cause. Our guess is that people with low VWF who are presenting with a bleeding phenotype probably do have other underlying hemostatic defects that we are just not able to detect in 2021. So all of this data and the studies that have been done recently really serve to support Evan's original hypothesis that low VWF levels sometimes represent a risk factor for bleeding and sometimes represent a bona fide disease. Clearly, there is a desperate need for more research to define the relationship between reduced plasma von Willebrand factor levels and how they impact upon bleeding phenotype. The second question that we need to address is to define the relationship between von Willebrand disease and heavy menstrual bleeding and postpartum bleeding. All of you will be aware that menorrhagia is common in women with von Willebrand disease. Up to 80% of women with VWD may experience heavy menstrual bleeding. In addition, up to 50% of women with von Willebrand disease may have depleted iron stores and indeed even iron deficiency anemia. Conversely, we also know that von Willebrand disease is actually common in women presenting with menorrhagia. So in adult clinics, perhaps 13% of those women will have underlying von Willebrand disease, and that number may be even higher in adolescents suffering with heavy menstrual bleeding. This heavy menstrual bleeding and indeed postpartum hemorrhage is also something that we see in women who have got mild to moderate reduction in von Willebrand factor levels. So these are data from the Lovick study, and as you can see here, both menorrhagia and postpartum hemorrhage are two domains in the bleeding scores where women are scoring very heavily. The heavy menstrual bleeding in women with low VWF also has direct clinical significance. Of the Lovic patients who had menorrhagia, 2/3 of them had required previous treatment with hormonal therapy. 1/3 of them had required treatment with iron. 25% of them almost had required a D&C for their menorrhagia. And astonishingly, almost 10% of them had actually undergone a hysterectomy to manage their menorrhagia. In addition to that subjective data from the bleeding scores, we also have objective evidence of the clinical significance of heavy menstrual bleeding in women with low VWF. Even after diagnosis and registration in the National Coagulation Centre in Dublin, we observed that almost half of the Lovic females had evidence of reduced ferritin, and almost 20% of them had evidence of iron deficiency anemia, providing objective evidence of the significance of their bleeding. During pregnancy, we know that plasma Willebrand factor levels increase into the normal range, and this was seen in the majority of our Lovic patients. Importantly, however, postpartum hemorrhage was reported in 63% of our Paris women, and more than 20% of those women had required intervention in the form of transfusion or critical care. Clearly, these data are telling us that despite the increase in von Willebrand factor levels seen with pregnancy, these are not necessarily associated with a complete correction in bleeding phenotype. Interestingly, heavy menstrual bleeding appears to be more common in women with von Willebrand disease compared to other bleeding disorders. So these are recent data from a study published by Declan Noon and colleagues. And as you can see, 70% of women with von Willebrand disease reported heavy menstrual bleeding, which was significantly higher than seen with other types of bleeding disorders. The mechanisms underlying that increased bleeding associated with von Willebrand disease remain unclear. However, it's interesting that recent studies have identified novel biological roles for von Willebrand factor beyond hemostasis. And in particular, we are seeing roles for von Willebrand factor in terms of inflammation and in terms of angiogenesis. That's particularly important because we don't understand how von Willebrand factor impacts endometrial biology in vivo. However, this process is obviously characterized by cyclical angiogenesis, followed by bleeding, which is in turn followed by controlled inflammation and repair. Clearly, there is a need, an urgent unmet need, for more research to define the relationship between von Willebrand disease, angiogenesis, inflammation, and heavy menstrual bleeding and postpartum hemorrhage, respectively. The third research question that we need to address is to define the relationship between von Willebrand disease, bleeding risk, and aging. For many years, we've known that plasma von Willebrand factor levels increase in the normal population with age. More recent studies, including this one from the Paula James Laboratory, have demonstrated that plasma von Willebrand factor levels also increase in age in some patients with type 1 von Willebrand disease. In this study, they had 31 patients with von Willebrand disease who were followed for more than 5 years. And during that time period, 18 of the 31 patients had von Willebrand factor levels that actually corrected to within the normal range. Conversely, data from the WIN study in the Netherlands have demonstrated that there is no age-related increase in von Willebrand factor levels in patients who have got type 2 von Willebrand disease. For patients who have low von Willebrand factor levels, we also see this increase into the normal range with aging. So in the Irish study, we studied 64 patients who had low VWF, again followed for more than 5 years, and you can see that 29 of those 64 patients did correct to within the normal range. Interesting data from the Netherlands from Frank Liebeck and colleagues have demonstrated that comorbidities impact upon plasma VWF levels. So shown in this figure, you can see the effect of hypertension, which is in the grey hashed boxes. Hypertension is associated with an increase in von Willebrand factor antigen, collagen binding, VWF activity, and factor VIII levels in patients with type 1 von Willebrand disease, but has no significant effect in patients who have type 2 von Willebrand disease. Similarly, we also see an effect of diabetes and cancer on plasma von Willebrand factor levels in type 1 VWD patients. If we start combining these comorbidities, we observe synergistic effects on plasma VWF levels in type 1 VWD patients. So as you can see, the VWF antigen level increases from people who have no comorbidities through 1 through 2. What this is telling us, of course, is that comorbidities may play an important role in contributing to the age-related effects that we see on VWF antigen levels. Perhaps the most interesting part of the studies that have been performed in the WIN cohort, though, show us that bleeding phenotype is not necessarily corrected in VWD patients, despite this age-related normalization in VWF levels. So in the WIN study, they collected patient-reported bleeding episodes in the year preceding inclusion and during life. As you can see on the left there, von Willebrand factor antigens increase progressively with age in these patients. But on the right, you can see that although the VWF levels have gone up, the prevalence of bleeding actually goes up with age. It does not get corrected. So similar to what we observed in terms of postpartum hemorrhage, we need to be conscious that the increase in VWF levels is not necessarily associated with a complete correction in bleeding phenotype. So once again, we do need significantly more research in order to elucidate the biological mechanisms underlying the effect of age on plasma VWF levels and the bleeding risk, particularly as the population continues to age. The fourth research question that needs to be addressed is that we need to define the pathobiology underlying reduced plasma von Willebrand factor levels in patients with low VWF, particularly since this is the commonest type of von Willebrand disease. The first critical message is that the majority of patients with low VWF do not actually have VWF gene mutations. This is data from the LOVIC study performed in collaboration with Jorge de Paulo, showing that sequence variants were identified in a small number of patients, but in the majority, nothing was found. Nevertheless, low VWF levels do appear to be inherited in some families. Once again, there are similar data from the Zimmerman program where VWF variants were more common in patients who had markedly reduced plasma von Willebrand factor levels compared to the low VWF cohort. Our data suggest that reduced VWF biosynthesis contributes to the low VWF levels. For example, the factor VIII to VWF ratio is increased in patients with low VWF. Platelet von Willebrand factor levels are reduced in the LOVIC cohort compared to healthy controls. Interestingly, however, there is a wide spread in platelet VWF levels, suggesting that the pathogenesis of low VWF is likely to be multifactorial in nature. Over recent years, we've gained insights into VWF clearance biology, both physiological and pathological. We've identified a number of scavenger receptors and lectin receptors, particularly expressed on macrophages on endothelial cells. Previous studies have also shown that pathological enhanced VWF clearance can also cause type 1 von Willebrand disease. In those studies, a propeptide antigen ratio greater than 3 was used to define patients who had type 1C von Willebrand disease. In the LOVIC study, we found that only 6% of our low VWF patients had ratios greater than 3. However, there was a significant difference in the propeptide antigen ratio between the low VWF cohort compared to the normal controls. And in particular, lots of the low VWF cohort were clustered around the 2 level. If you do the maths on this, it turns out that quite a number of the low VWF cohort actually had VWF half-lives of less than 6 hours, clearly suggesting that subtle enhanced clearance, together with reduced VWF biosynthesis, may contribute to the pathogenesis of low VWF. So again, we desperately need more studies in order to define the pathological mechanisms that contribute to reduced von Willebrand factor biosynthesis and enhanced VWF clearance that are occurring independent of the VWF genetic locus in patients with low VWF. And as many of you will know, this is the focus of the ongoing Zimmerman program at the moment. The final research question that we need to think about is how we can improve treatment for patients with von Willebrand disease. You'll all be aware that there are a number of well-established treatment options for patients with von Willebrand disease. These include antifibrinolytics such as tranexamic acid, desmopressin or DDAVP. There are a number of commercial plasma-derived von Willebrand factor-containing concentrates. We also have platelet transfusions, adjunctive therapies such as the oral contraceptive pill or the Mirena-Coy. And we have the option more recently of a first recombinant von Willebrand factor, Vonvendi or Vayvondi from Takeda. However, when it comes to the management of bleeding and hemostatic challenges, there remain significant questions about optimal therapeutic targets and duration of treatment. A number of different guidelines are shown in that table, and as you can see, for major surgery and minor surgery, the recommendations in terms of therapeutic target and duration differ significantly. This question was also addressed in the most recent ASH guideline, where the panel suggested targeting both factor VIII and VWF activity levels were maintained above 0.5 IU per mil for at least 3 days after surgery. However, as I mentioned before, this was a suggests rather than a recommends because there was low certainty in the evidence. So important questions remain. For example, do these patients need thromboprophylaxis? If so, when should it be started? And how do we manage any post-op bleeding that may occur in these patients? In addition, we also have to think about the management of bleeding and hemostatic challenges following apparent normalization of von Willebrand factor levels. As I've already mentioned, that can happen with aging, it can happen during pregnancy, but the data that we have, particularly from the WIN study, suggested that apparent normalization in VWF levels is not necessarily associated with a complete correction in bleeding phenotype. So how do we define optimal therapeutic targets for these patients? And do these targets need to differ for individual patients? From all of the data that I've shown you, I think it's very clear that patients with von Willebrand disease are heterogeneous in nature, and consequently we cannot expect that a one-size treatment option for von Willebrand disease will fit all. Instead, what we need to do is to introduce personalized medicine into the field of von Willebrand disease so that treatment options are tailored specifically for individual patients, so that we are aware of the guideline recommendations, but that we also consider patient-specific aspects. Key to all of that is that the patient is at the center of the multidisciplinary team decision-making process. Patient preferences need to be considered, and patients need to be empowered so that they can be actively involved in the decision-making process. The other thing that's readily apparent is that treatment for von Willebrand disease has lagged significantly behind advances in the haemophilia field. This is a nice image that I've taken from a recent review published by Cécile Denis and colleagues in Blood. As you can see, back in the 1960s, both haemophilia and von Willebrand disease was being treated with cryoprecipitate. Since then, there have been significant advances in the haemophilia field, right through to extended half-life products, non-factor therapies, and most recently gene therapy. In contrast, for von Willebrand disease, we have only recently got our first single recombinant concentrate. We have significant clinical experience of using primary and secondary prophylaxis for patients with severe haemophilia. However, in contrast, the data for prophylaxis in von Willebrand disease are very limited. Perhaps the best data come from the VWD prophylaxis network. In a retrospective study, they enrolled 61 patients from 10 countries. More than 90% of the patients had type 2 or type 3 von Willebrand disease. The patients had a median age on starting prophylaxis of 22 years. And the typical VWF dose at starting was 50 units per kilogram administered 2 to 3 times a week. The study demonstrated that there was a significant reduction in bleeding associated with prophylaxis in severe von Willebrand disease. Interestingly, however, prophylaxis was more effective in preventing some types of bleeding, particularly hemarthrosis, compared to others where it was less successful, in particular gastrointestinal bleeding. I'm glad to say that the ASH guidelines have highlighted the need for prophylaxis in von Willebrand disease. In patients with VWD with a history of severe and frequent bleeding, the panel suggested using long-term prophylaxis rather than no prophylaxis, and remarked that bleeding symptoms and the need for prophylaxis should be periodically assessed. However, this is once again only a suggests, because again, there is low certainty in the evidence of the effects. So there are important unanswered questions here. How do we select the VWD patients who need prophylaxis? What is the optimal prophylaxis treatment regimen? Is there a role for personalized dosing based on individual pharmacokinetics? And of course, we need pharmacoeconomic analysis here. In short, there is a need for future adequately powered clinical trials in order to define the best role for prophylaxis in patients with von Willebrand disease. Towards that aim, Robert Sidonio and I have been trying to launch a new von Willebrand disease prophylaxis network 2.0. This is a program that is ongoing and has support from the previous steering committee of Tom Abshire and Eric Berntop. And I hope that you will hear more of this in the coming months. In addition, it's important to highlight that there are some recent novel approaches that are being developed towards improving the treatment of von Willebrand disease. These include a number of different genetic approaches, together with a number of protein-based therapies. And hopefully these advances will lead to improved management of our patients in the near future. So, for sure, there is the need for future research in order to improve optimal management for patients with von Willebrand disease. In the final few slides of the presentation, I want to have a look towards the future. How can we address the key outstanding issues in von Willebrand disease that remain? The one thing that is for sure is that we cannot do what we have been doing in the past. What got us to where we are today is not going to get us to where we need to go to in the future. In the past, our research on von Willebrand disease has typically involved small studies that have been inadequately powered, often single center. They have tended to be retrospective, almost all non-randomized. We have tended to use study endpoints based on the haemophilia literature, and there has been limited science involved. In order to move this field forward, what we now need are large international collaborative studies. We need to remember that von Willebrand disease is not a rare disorder, and so large studies are entirely plausible. These large studies would allow subgroup stratification and multivariate analysis. The studies need to be prospective and randomized. They need to include state-of-the-art science with multi-omic strategies. And where possible, these large studies should not solely be dependent upon pharma funding. I think an important step towards establishing those studies, again, has come from the recent ASH guidelines, where in addition to the 2 guidelines, all of the authors contributed to a set of proposed definitions that can be used to underpin future research in the field. So in conclusion, I think there have been significant advances in our understanding of von Willebrand disease, but key clinical questions remain to be addressed, both in terms of diagnosis and clinical management. There is an unmet clinical need on a global basis because von Willebrand disease continues to be associated with significant morbidity. It's obvious that the von Willebrand field has lagged behind recent advances in haemophilia, and I think the recent ASH, ISTH, NHF, WFH guidelines highlight many of the issues that are involved here. I think these guidelines need to serve as a wake-up call or a call to arms for the community. And I hope that the NHF will be able to play a key leadership role in developing the kind of studies that we really need in order to advance the outstanding or to address the outstanding questions in the field. And with that, I thank you all for your attention, and I'll be happy to take any questions.
Good morning. I would like to welcome everyone to the State of the Science Working Group 2 presentation. And we are the group that focused on von Willebrand disease, platelets, and other mucocutaneous inherited bleeding disorders. And I want to thank Drs. Valentino, Recht, and the NHF for the opportunity to present today on behalf of our working group. I am one of the co-chairs of Working Group 2 along with Robert Sidonio. Dr. Sidonio will be completing this presentation, so I will hand things off to him midway. And as I think everyone knows, he is a fantastic hematologist who comes to us from Emory University in Atlanta. And I am a pediatric hematologist up in Milwaukee, Wisconsin. So thank you for joining us, and we hope that this presentation invites a large number of questions at the end. I am presenting, and Dr. Sidonio is presenting on behalf of all the fabulous members of Working Group 2. And although we have limited time for this presentation, I really do want to call out each of these individuals. This is a fantastic group of people and includes Paulette Bryant, Sarah Hale, Meadow Hyman, Shelley Horowitz, Christy Humphrey, Laura Joyner, Barbara Conkle, Nicole Scapie, Kelly Tickle, Jorge DePaula, Julie Jaffrey, Raj Kathuri, Peter Kuides, Cindy Lessinger, Bob Montgomery, Keith Neves, Anna Randy, Christina Tarango, Pamela Trepane, Michael Wong, and Brittany Waters. And as you can see, this group contains a varied expertise. We have hematologists, both from the pediatric and adult side. We have experts in basic biology, including microfluidics and angiogenesis. We have experts in Ehlers-Danlos syndrome and HHT. We have varying disciplines, including dental care, genetic counseling, social work, physical therapy. We have advanced practice nursing and several patients, as well as industry represented in this working group. And I think that's important because it's this variety of different opinions that allows this work to be so applicable. I do want to acknowledge that this is a fairly heavily medical group and fairly high-resourced group, and I think we'll look forward in the question period to see if there's other points of view that people want to put forward. But the data I'm presenting today is on behalf of all the people here who really contributed to making this presentation. All right, so to our mandate. Working Group 2 was given the topic of von Willebrand disease, platelets, and other mucocutaneous bleeding disorders, which is a rather broad subject. We were also asked to cover both multidisciplinary basic and translational research aspects, as well as clinical studies and clinical trials aspects, and specifically asked to consider on the basic and translational research side, therapeutics, including novel therapeutics, ease of administration of these therapies, and gene therapy. In the diagnostics category, we were asked to consider disease-specific functional assays, genetic testing, and genomics and phenomics. And then mechanisms of disease, including the biology of mucocutaneous bleeding. And this will come up over and over again as one of the major themes of our presentation, that this is an area that is not well understood and is inhibiting our ability to make progress on the diagnostic and on the therapeutic side. And then, as if this wasn't enough, we were also asked to consider clinical trials, such as post-licensure therapeutic and regimen implementation and data collection, natural history data collection across races, sexes, gender, lifespan. And this was another of the major themes where we just don't have the information we need about how these diseases affect people across their lifespan. We were also asked to consider severity and phenotype, aging and comorbidities and quality of life, defining inherited bleeding disorder-specific clinical outcomes, and disorder-specific patient-centered outcomes. So these were the questions that our group was tasked with. There were several different topics we evaluated specifically. These include von Willebrand disease, inherited platelet defects, Ehlers-Danlos syndrome, and hereditary hemorrhagic telangiectasias as specific other mucocutaneous bleeding disorders. But we also added in the category of bleeding of undetermined cause. I think this category has a lot of names by different clinicians, but basically this is the people with mucocutaneous bleeding for which we don't have a specific diagnosis. We also considered very specifically and intentionally novel therapeutics, aging, and then the biology of mucocutaneous bleeding. The scoring system was the same as used by the other groups, and this is basically looking at the feasibility of the intervention, the impact of the work, and then the risk or acceptability of this to physicians and patients and care groups. So the topics were scored using this, and we have included what the scores of the various questions were here, so you can see what things were most prioritized by the group. And Dr. Sidoni and I will try to add in comments regarding the high scoring items as well. So, to summarize the major themes, although we still want you to listen to the rest of this presentation, the major themes include a better understanding of basic biology. And I would say this was the area where the most questions arose and the group felt the most questions needed to be prioritized. And this basically comes down to how do blood cells and proteins interact with their environment? How does this interaction differ in various tissues? And what happens to this interaction in patients with von Willebrand disease, Ehlers-Danlos syndrome, or hereditary hemorrhagic telangiectasias? Another key theme was the natural history of mucocutaneous bleeding disorders. What happens as patients age? What happens across the lifespan? What are the differences? And what are we failing to take into account as our patient population grows older? Another question that recurs throughout this is better diagnostic testing, and in some cases, better definitions for these disorders. Because if we don't define specifically what we're looking at, this makes all our outcomes less clear. And then I would also say that creative use of novel therapies came up over and over again. Are there things that we could be doing or using more creatively to bring relief to the patients with these disorders? So I am going to present a little more specifically on the topics of mucocutaneous bleeding and von Willebrand disease, and then hand things over to Dr. Sidonia. So the biology of mucocutaneous bleeding was the section that had the highest number of questions the group felt were high priority. And I think this speaks to the fact that for many of these disorders, we don't really understand the basic biology. And so that is limiting our ability to properly diagnose them and then secondarily to treat them. Some of the questions that the group felt were extremely high priority include defining the differences in the biology in the various parts of the mucocutaneous locations, such as environmental differences between the GI tract, nasal tissue, and uterus. Are there different mucins? Are there different rheologies in these areas? In patients with von Willebrand disease, is there an inherent defect in wound healing? And if so, in which tissues? What is the role of hormones, including gender, menstruation, pregnancy, and perimenopausal time period on the vessel environment related to mucocutaneous bleeding? Can we characterize the pathways mediating the interaction of platelets and plasma proteins with the different tissue-specific vascular beds in extravascular space? What's the role of vascular mural cells, such as the pericytes, in the control of hemostasis and mucocutaneous bleeding? Are there functions of von Willebrand factor in regulating vascular integrity and other functions that are not currently measurable, which could contribute to mucocutaneous bleeding? What is the contribution of blood vessel-associated pathways in the extracellular matrix and the microenvironment to mucocutaneous bleeding? These are areas we do not study well at all at the present time. How do we develop better animal and in vitro, such as organs and blood vessels on a chip models, that will better capture the contribution of the microenvironment to mucocutaneous bleeding? What is the role of the interaction between von Willebrand factor and various proteins, extracellular matrix proteins, growth factor interactions, for example, in the regulation of hemostasis and vascular integrity? And then what is the biologic difference in the microenvironments of EDS and HHT as compared to von Willebrand disease? These are separate disorders, and they are most likely affecting that microenvironment differently. And obviously, these questions took up multiple slides, and our group did discuss that fact. And what I want to bring up here is the group really felt that all of these questions were extremely high priority for the field. And I think this gets back to the fact that we don't necessarily understand what's going on at the tissue level. We don't understand what's going on at the cellular level. And that is impeding our ability to make progress on treatment. It's impeding our ability to properly diagnose patients. If we're not looking at the areas where there's a key problem, but instead we're just focusing on plasma protein levels, we may be missing the biggest part of these patients' problems. And we may not be treating this the way that it ought to be treated. So this is one of our major themes here, and I did want to take some time on it because the group felt very strongly that this was a high priority area. Obviously, some of these studies are going to be more feasible than others, and some of the studies are going to be more difficult to perform. But the thought was that the potential impact to affected patients was going to be so important that these studies really need to be performed. Right. I am going to conclude my part of the presentation with von Willebrand disease. I admit I specifically asked to get to cover this one. And I think the themes here are somewhat similar. Several regarding the longitudinal care of these patients, several regarding diagnostic testing, and then treatment. So the highest priority questions in the von Willebrand disease realm were the longitudinal characterization of joint health in patients with von Willebrand disease. We've done a lot of work in this area for patients with hemophilia, but much less in von Willebrand disease. Improvement in diagnostic von Willebrand disease testing that does not rely on specialized coagulation labs, potentially difficult but of major benefit to the community. Can emicizumab be used effectively as subcutaneous therapy or prophylaxis for patients with severe von Willebrand disease, but potentially even for mild to moderate von Willebrand disease? Another area of extreme importance is what can be done to better understand the male journey with von Willebrand disease. Women have the option of being diagnosed because of their heavy periods, even if that diagnosis is delayed. Male patients may often struggle in silence, and I think that was for our group a major concern. And then potentially a little more clinically relevant, how can we use anti-angiogenesis agents for the management of certain bleeding symptoms in patients with severe von Willebrand disease? And I think this gets back to if we better understood the biology at a cellular level, there might be opportunities that we could employ these anti-angiogenesis agents, perhaps most specifically in patients with GI bleeding, but there may be other opportunities that we're missing to use drugs that are already in existence and apply them to this population. I do want to also acknowledge that there are some questions about aging in von Willebrand disease, and particularly cardiovascular disease, that were wrapped up in the aging section that Dr. Sidonio will cover in a few minutes. So to conclude my part of the presentation, that's the areas that were thought to be the highest priority in the biology of mucocutaneous bleeding and in von Willebrand disease. And I'm now going to turn it over to my fantastic co-chair, Dr. Robert Sidonio, to talk about the other areas that our group focused on for this presentation. Thank you for your time, and here you are, Dr. Sidonio.
Thanks. Well, so let's continue. Thanks, Veronica. I'll take it from here. So let's keep it moving for working group 2. The next topic is inherited platelet defects. We had a number of research priorities that we scored, with the majority reaching at least a moderate score. The first one is the natural history in patients with mild qualitative platelet defects. We also wanted to make sure that we captured quality of life and then really what happens over time with their bleeding symptoms. As most of you know, we have very little data on mild qualitative platelet defects, likely because of poor diagnostic testing and a seemingly large number of patients with varying defects in their platelets. The next research priority was how can we optimize the management of mild qualitative platelet defects? Obviously, the first two could be part of a study, make it a little bit more feasible. The next two questions are listed here. One of them was related to the relationship of the medications and certain types of mild qualitative defects. And finally, one that we wanted to make sure that was in here was how do we improve and standardize platelet function testing? Right now, we mostly rely on whole blood impedance or light transmission aggregometry. We really feel like there needs to be a standardization for diagnostic testing. Oftentimes, most of us continue to repeat it until we feel like, one, they don't have it anymore, or two, there's a consistent pattern. And it's fraught with all kinds of other pre-analytic variables that certainly are worth investigating. So as mentioned before, our group had a large number of disorders that we were taking on. So not only we were taking on von Willebrand's disease, mild qualitative platelet defects, we also wanted to make sure that we had a larger tent that included Ehlers-Danlos syndrome, hereditary hemorrhagic telangiectasia, and then finally bleeding of unknown cause or bleeding disorder of unknown cause. So we think this is an important group of disorders that could benefit from our infrastructure. So the first research priority that we had was how can we define a cohort of patients with a bleeding of unknown cause, and can we characterize them longitudinally? Obviously, we wanted to include definitions and the standardization of the workup to exclude other causes. There are a number of papers that are likely being pressed soon, some work being done by Dr. James O'Donnell and Dr. Will Thomas and other members in England and Ireland at this time. We also wanted to see, could we actually create a collaborative effort in the longitudinal evaluation of these aforementioned disorders within our HTC network? We know that HHT has their own network, and there's some efforts right now and looking at how can we combine our efforts. Additionally, we wanted to look at the role of iron deficiency, how it both affected bleeding and the thrombotic risk in HHT, and what the risk was overall of HHT. Why does it happen? What situations are likely to make it occur? And can we determine the prevalence depending on mutation type? And then finally, we wanted to look at what was the mechanism of the actual coagulation defect in HHT. Is there something that we can do to mitigate that as hematologists? So moving on, there are a few more that we identified that didn't get scored as highly, but the group really felt strongly, even though they didn't get a very high priority score, that it was worth the investment of time. And obviously one of them was, what is the appropriate hemostatic evaluation, particularly how far do we go down the rare fibrinolytic pathway defects? And is there a role in evaluating a TFPI in these disorders? There was a nice talk recently by Will Thomas on this topic. Moving on to the next one, a number of us wanted to really focus on a national biorepository in which we can collect these samples, and hopefully there'll be a future breakthrough, maybe a discovery of certain defects that may be able to elaborate some of those that have bleeding of unknown cause. And certainly there are a number of us that believe that those with low VWF that have very high bleeding scores may actually have bleeding of unknown cause, and the low VWF may be a red herring. Obviously, it's still under investigation. And then finally, Even though it didn't get a high priority score, we really hope that there'll be a better molecular diagnosis that can confirm hypermobile EDS particularly. So moving on to novel therapeutics, some of this was covered a little bit in the VWF. Unfortunately, there's not been a lot of work in evolving the way we manage VWD. One of the first topics that we wanted to cover is aptamer-based treatments for the hemostatic management of mild mucocutaneous disorders. This got a fairly high score. We know that there are efforts underway in looking at some of the newer aptamer-based treatments that may actually be helpful for mild hemophilia and von Willebrand disease. A number of us were interested that is it feasible to modify VWF to be given subcutaneously? Many efforts to modify it in factor VIII have failed, continuing to show inhibitor developments. And right now we don't have the technology, talking to our industry colleagues, but certainly something to consider if there's a breakthrough in the future. One of the other things is that we have a number of drugs in our armamentarium. Are there potential crossover potential to treat bleeding of unknown cause, mild qualitative platelet defects? I think this would align with some of the studies that we mentioned in the previous slides. And there's some efforts underway looking at genetic differences in the endothelial cells that may affect those that have good responses versus poor responses to DDAVP. And can we optimize DDAVP for the management of bleeding in von Willebrand disease? Right now, when we have our intranasal drugs, they only have 2 different doses. There's a questionable max dose. And so I think, a number of us were hoping that maybe we can optimize this better than 2 standard doses. So obviously aging was a big topic that we wanted to cover. A number of high priority research questions here. The first one is, like other disorders mentioned here, is what happens over time with those that have mild mucocutaneous bleeding disorders with their joints and with aging, and does this evolve over time? A number of our patients and advocates really wanted to see how this affects ADLs or activities of daily living and ability to get their own venous access. Does quality of life change over time with this population? Is there an effect on bone and joint health? There's a number of studies looking at this, and obviously there needs to be a focus in mild mucocutaneous bleeding disorders. So not only just von Willebrand's, but platelet defects, and is it alter over time? Hopefully one of my colleagues, Dr. Sridhar, will be able to present her data at the ASH meeting in the next couple of months. Moving on to the other ones, how can we optimize antiplatelet therapy for our older patients that are developing cardiovascular disease? And is there a way that we can do this in a safe way? Obviously, acknowledging the mild platelet defects that they may have. One of the things that's interesting is that some of us feel like the surgical bleeding risk evolves over time. Maybe it's gets better over time, but obviously something worth describing. And one of the things that we obviously have to tackle, it's been addressed a little bit in the VWD question, is what happens over time with our VWF levels. We know that they rise, but there may be age-appropriate norms. What levels are needed to prevent bleeding based on their age? There's probably a reason that our levels rise with age, and we may need higher levels of VWF to mitigate the bleeding. And one of the big questions that I have as a pediatric hematologist is, can you outgrow VWD? Some of us feel that it potentially is a spectrum disorder, and it's always been viewed as a potential risk, particularly those with mild reduction that fit in the previously categorized section called low VWF. And so that's our research priorities. Hopefully, those have we've laid out, hopefully will inspire those that are watching this to get involved, to get inspired to consider their own research studies. And so we had a number of questions. Why would we get involved? Obviously, we want a chance to shape the research priorities. When we were doing this, we identified a significant knowledge gap in mucocutaneous bleeding biology. This was the field that I wasn't really aware of. A number of our working group members really set out a nice agenda we were able to set out a pretty ambitious agenda, but one that I feel that will be helpful for a number of our colleagues. We feel like this was a nice way to really get a large tent, a large number of voices from multiple areas, including patients, advocates, physicians, physical therapists, dentists, social workers, basic biology researchers, and of course our industry representatives. It's important for them to see what we feel is an important research agenda. So what are we hopeful for these outcomes? Well, obviously hopefully we can identify research projects that can really hone in on specific questions that we feel strongly as a community that need to be answered. We hope this will continue to improve the engagement in von Willebrand's and mild bleeding disorder research. I think the first step was the VWD guidelines. There are a number of papers that are going to come out related to that, and we hope that we'll continue the discussion in von Willebrand's, and not forgetting about our patients that don't get as much attention in mild mucocutaneous bleeding disorders and the qualitative platelet disorder defects. Obviously, we're hopeful that this will inspire collaborations and be able to help set priorities for a number of our industry and our patient advocacy groups for future grant funding. So why should you be excited? Well, I mean, we handpicked these. We had a large group from a diverse background that felt very invested in these outcomes. And so we hope that this will help make it a little easier to identify what we should be focusing on the next 5 years. We've outlined a large number of key priorities in the mucocutaneous bleeding biology, and I think this is really going to be interesting moving forward. We really are hopeful that this will inspire collaborations across our fields, really looking at our EDS, HHT, and bleeding of unknown cause colleagues, and really try to do a better job of improving the diagnosis and management of those disorders. There are a number of broad implications that come out of this. We feel like this was a good model for determining research priorities. We're hopeful that this will be an ongoing effort with NHF, hopefully reaching out to other groups as well to get involved in setting the agenda for the future. I think it's a good model for a community engagement. No one does a better job than NHF at reaching the community, really trying to set the agenda and engage providers to get involved. And obviously, we are hopeful that they'll be able to disseminate these ideas to the bleeding disorder community, work with our other patient advocacy groups as well, and then really work with our number of organizations that were involved in this and represented by our colleagues. I know we mentioned our members again, but I really want to mention them again. We couldn't have done this. Veronica and I definitely could not have done this without a lot of involvement. This happened during the summer, a very compressed timeline. We had vacations. A number of us were in time zones that made it very difficult. And then our steering committee member, Dr. Barbara Conkle, was really helpful in moving forward, answering our questions, because this was a new effort, and we're really grateful for her effort as well. Obviously, I'm very grateful for my colleague on this, Dr. Veronica Flood. I could not have done this. Hopeful to be able to work with her in the future. And this is the time where hopefully we'll open it up for discussion and lots of questions. Thank you very much on behalf of our working group members and Dr. Veronica Flood. Thank you.